questioned the possibility of what is known as terminal sedation, but the precarious ethical framework around this again made its approach untenable. I recall vividly having to give this gentleman very large quantities of morphine plus significant regular top-ups just so that he could be turned in his bed. Every time this happened, he screamed out in pain, and his mother, a lovely lady who I still look after to this day, came to see me a few weeks later. Her words still ring in my ears. "My son died in pain," she said, and I had to agree. The next example didn't directly affect me. I was actually on holiday with a medical colleague whose son works as a paramedic in the south of England. He'd been called to a terminally ill man who had a tumour invading his carotid artery in the neck. When he arrived, this man was bleeding out with blood literally spraying everywhere, such that my friend's son got covered in it. He needed to talk to his dad and subsequent counselling. How on earth did the patient's family feel? And what a horrible death for the man concerned. I actually took the trouble to look up the palliative care guidelines on how this scenario should be dealt with. You have to understand that these major bleeds that can affect particularly structures in the neck and in the abdomen aren't usually isolated. Sometimes there are several before the terminal event. And the standard response of the palliative care guidelines is that green sheets should be laid over the bed, so the blood loss is less evident. And treatment with a drug called midazolam, it's a sort of IV Valium, is given so that the patient is ostensibly unaware. Firstly, it takes time for any drug to work, particularly in such an acute situation. And secondly, the comment was made again in these same standard guidelines that if the patient had to go through the same thing again, then that was okay, as he or she would not remember. Really? The last is a more common example and something that struck a chord when I was in the audience of a similar meeting to tonight, the assisted dying debate at the Arts Centre on 11th of September 2019, when Sylvan was speaking alongside Gavin Ashenden at the event chaired by our inspirational Gary Burgess. It was from a lady who praised the truly wonderful people at the hospice for what they'd done for her father. He had spent a considerable amount of time there. Before the end, he'd lain there semi-conscious with no quality of life for some weeks. He was comfortable, but she stressed this was not the prolonged death he had asked for, or indeed wanted. In all of the three scenarios I presented, there was no choice. Whether it's a case of someone being unable to face physical, spiritual, emotional, or psychological pain, surely one size fits all is not the way. Further, when considering the above from both an ethical and philosophical perspective, I'm struck by the illogicality of our current approach. Again, I'd like to cite three examples. Jersey has an abortion law which was introduced in the early part of my career, well after the UK. Prior to that, we had to declare young women of being of unsound mind, that was the term, for them to have a termination locally. Otherwise, they were sent away to another jurisdiction, in this case the UK, to have the procedure. Does this sound familiar? Eventually, there was a debate in the States, and the arguments were heated on both sides. And in the end, as we all know, the abortion law came to pass. The law in Jersey was not the same as that in the UK, with other caveats such as a cool-off period and a limit of 11 weeks. It nevertheless worked well, and hand in hand with improved contraceptive services, we've seen a reduction in the number of terminations as time has gone by. My experience is that almost every woman agonises over the decision, which legally falls to her about someone else's life rather than her own. Some doctors are conscientious objectors, while others counsel their patients as to what is best for them, and there is a centralised provision of service. The illogicality is, how is it our society is convinced that someone can decide about someone else's life, but they can't decide about their own? Further, that this life, or potential life, would certainly be much longer than one involved in end-of-life choices will be debated next week. The second illogicality, in part, relates to what I described as the situation some years ago regarding termination. The fact that as yet we won't consider assisted dying in the UK, or indeed here, but we've already softened our law in terms of someone travelling to a different jurisdiction to obtain it. Many years ago, suicide was considered a crime, and then the law was changed. Initially, and Sylvan will correct me if I'm wrong, those helping their loved ones to go to Dignitas were technically subject to prosecution for doing so. Once again, the position of the law has been tempered because of the nature of the problem. The illogicality is, how is it we can accept this, and yet we cannot accept that on the rare occasion someone does want to end their life when they have a life-threatening condition. We can't allow this on our own turf. The third piece of illogicality relates to the arguments that are persistently rolled out in opposition of an assisted dying law. It would be unregulated. Legal assisted dying practice overseas receives much more independent scrutiny than end-of-life care options currently legal here, such as palliative sedation or the withdrawal of life-sustaining treatments such as ventilation and clinically assisted hydration. Legalising assisted dying would be far safer than the status quo. It would lead to a slippery slope. No laws introduced for terminally ill, mentally competent adults have ever been extended. I'll say that again because it was a surprise to me. No laws introduced for terminally ill, mentally competent patients or mentally competent adults have ever been extended. The Benelux countries and Canada had much broader laws from the outset. Any changes to the US legislation have reduced barriers to access, but have not expanded eligibility. It would result in less emphasis on palliative care. The vast majority of people in Oregon, California and Victoria who have had an assisted death were already enrolled in hospice and palliative care. The Oregon Hospice and Palliative Care Association was initially opposed to law change, but now supports the rights of Oregonians to choose or not to choose any and all legal end-of-life options. The point is, we're not blazing a trail here. Something like 200 million people around the world have introduced a form of assisted dying legislation, and no country has rescinded it. It varies from jurisdiction to jurisdiction, and we have the opportunity to choose our own, exactly as we did with abortion. If we look at legal processes that are more similar to our own, often Anglo-Saxon based, and Oregon as an example, after 20 years there's been very little slippage, as one might term it, in regard of numbers. Only about 0.6% of the eligible population actually seek assisted dying. Even in Switzerland, with its more liberal laws, it's only 1.6%. And a sizable number of those who are prescribed drugs don't actually take them. Presumably either because they changed their mind or they are happy with the palliative care which is being provided. Either way, the important thing is they retain choice. And this is not an either-or, as has been suggested by one of my colleagues in a meeting earlier this week. A change in legislation can be introduced at the same time as improvement of other services, exactly as it was with the abortion law. When we talk about whether a law is introduced or not, what we're really talking about are the associated safeguards. A citizens' panel was convened by the Health Minister, and I had the privilege of joining Professor Sam Ahmedzai to speak to them at one of many sessions when they listened to arguments for all sides. He is an experienced palliative care physician of approximately my vintage, in other words, pretty old. I learned that he had changed policy against prevailing wisdom with regard to both introduction of morphine patches and syringe drivers in palliative care, both of which are now standard practice. But he also confirmed that palliative care was by no means a panacea, and that was why he was advocating a change in the law. It was evident to all on the panel that they had not only considered all the, it's evident to all of us that the panel had not only considered all the various options, but that the whole process was well organised, such that information was presented and digested in a form that made its deliberations as easy as possible. What was recommended has included those safeguards. Recognition of a threat to life confirmed by a doctor, possibly independently. A cool-off period, one presumes proportional to the prognosis, and a potential review by the courts, again timely and presumably as required to minimise the risk of external coercion. My mother, who is inherently against a change in the law, she is a strong Catholic, once put it to me that the introduction of an AD law would mean I could potentially finish her off. I pointed out that although she is 90, and those of you who know will picture her, it would be a brave doctor who would make the deliberation that she was about to die, and an even braver court that would support it. Seriously though, introduction of an assisted dying law is not an excuse to be blasé about life. Notably, the panel's decision and recommendations that they made were largely in line with local and national polls, such that something like 80% were in favour of an introduction of an assisted dying law. I see that there are politicians here in the audience tonight. Thank you for coming. It's extremely important to point out that you have been elected to represent the will of the people. It was you, through our health minister, who appointed a citizens panel. All the available evidence points to the fact that a sizable majority of the population support change in the law, and it is inherent upon you, our representatives, to take this into great consideration in the forthcoming debate, whatever your personal stance. I'd like to end with a quote from Rabbi Romain, who has recently written in the British Medical Journal in support of assisted dying, with, as one might expect, much subsequent comment. His reply was relatively simple. Opponents of assisted dying are welcome to live on until the last breath, be it painfully or peacefully. But demanding that someone else die in pain because of those principles is the height of arrogance. They worry about potential abuses in the future, but ignore people suffering here and now and crying for release. How sensible is it to let theoretical objections mean that definite agonies continue? Thank you very much.